Hello, thank you for joining my virtual class here today. We're going to go over tracheostomy and laryngectomy management. We're going to talk about some of the basics about either and both of those airways. We're going to talk about how to use them, some of the complications you might run into, and what you need to do if you do run into those complications. So we have tracheostomy Tom here. Oh, he's losing his NG tube. Tracheostomy Tom is our model that's going to kind of show us where the things sit in the trachea and how everything works. We also have joining us here Miss Daisy helping us, so if you hear any clickety-clacketing, please forgive me. She is around being a good helper. So let's get beginning. So these are our learning objectives. We are going to go through 5 of them to give the best understanding of trach care and laryngectomy care possible. So our objectives are to determine when a patient with a tracheostomy or a laryngectomy is having an emergency, and to compare and contrast the emergency management techniques for the 2 different devices. Demonstrate an internalization of the safety standards around tracheostomy and laryngectomy care, and justify your emergency nursing actions. Demonstrate how to properly suction tracheostomies and laryngectomy tubes, how to utilize a bag valve mask to ventilate both of them, and how to use speaking and humidification valves, and what tubes are used on which device. Then we're going to describe at least 5 early and 5 late complications that occur in each type of airway. And then we're going to formulate a comprehensive care plan using the nursing process to guide the care of these patients on a daily basis. So let's get started. So tracheostomies. Tracheostomies are a surgically created stoma that goes into the airway and provides a stable way for an endotracheal tube to get into the airway. So rather than being intubated through the mouth, which we are used to seeing, intubated through the tracheostomy is going to be a little bit more stable and a little bit more of a long-term solution than oral intubation. It may be placed emergently, and that would be in people who have like an emergent airway obstruction or conditions like that. It may be placed as a planned procedure, so someone who's been in the ICU and has been intubated and ventilated for a while may end up with a planned tracheostomy. It requires a plastic tube that consists of an inner and outer cannula to be placed into a surgically created stoma in the neck. And that device is usually held in place with ties. Sometimes there'll be like ribbon ties. We almost always see ties that are a Velcro situation. And usually there's a gauze dressing underneath to protect the skin as well. So your components of a tracheostomy, as we were just saying, there are 3 main components. You have your you have your outer cannula, which is the part that is kind of your main airway. Your inner cannula, which changes daily and keeps the trach, being able to remove mucus plugs and things of that nature. And then you have the flange, which is the part that sits up against the skin and is what your trach ties tie into. So tracheostomy Tom here, we're going to borrow his trach and kind of go through the components. So tracheostomy Tom here, you can see he has a cuffed trach. So he does not have an inner cannula in it currently. So we're going to open up an inner cannula. So his cuffed trach is there so that we can put him on a ventilator if we need to. There's some other pros and cons that we'll talk about in a minute. So we have his inner cannula. It just kind of slides right in and clips in. So you have the inner cannula in the trach now, and so then when you need to, it just pinches out and comes out. And then you have the cuff. You have this balloon inflates and tells you if the cuff is inflated internally or not. And then you have this flange that is what sits up against the skin, and in either of these 2 little holes here is where your trach ties will go. So we will give Tom his trach back. I'm sure he is missing it. Maybe. Hard to put it in one-handed, forgive me. So other equipment that might be present, you might have a speaking valve, like we discussed, like a passing mirror valve or a humidification valve. The patient might be on a ventilator, and then the ventilator tubing would be in addition to the trach. And those may also be present. Emergency equipment, you always need to have an extra trach and an ambu bag, and we'll discuss those later in more detail. So your components, as we talked about, you have here, this one is the Shiley trach, is a brand name of trach, which is what most of the trachs are that we see at this point. So this is your Shiley trach. This is your outer cannula that has the flange. So if you had a uncuffed trach, that's what that would look like. And then over here is your inner cannula. So demonstration, we kind of just already jumped the gun on that a little bit and talked about the different pieces. So that is how the trach kind of all fits together, and then it fits inside the airway here. And so I'll bring tracheostomy Tom a little bit closer here so you can see. So this is Tom. He's ready for Christmas, as you can see. So the trach sits here. This is his trachea. You can see it attaches to his, this is his mouth right here, breathes through the oral cavity and then down into the trachea. This is his NG tube because Tom is an ICU patient. He's got a lot going on. So we have his NG tube in there, and that shows you where his esophagus is as well. So his esophagus is back here. His trachea is here. You can see that it's clearly got some delineation there. So the trach sits here in the airway. You can see that it's got some room to wiggle. We don't want the trach to be like butting up on the sides of the airway, so we can downsize it if we need to and upsize it if we need to. Most Shileys come in size 4, 6, and 8, so there's some wiggle room in size. This is a size 6 that Tom has on currently. So that's kind of the anatomy of the trach. We'll put him down for right this second. All right, so cuffed versus uncuffed. We talked some about that. So the cuffed trach is important because it's going to occlude this entire airway. So when we have a ventilator, we want no air to be seeping out around the trach. We want to be sure that we have the right pressures in the ventilator and that the patient is getting everything that they need through it. So the trach will be cuffed so that no air is getting on the sides. So we'll demonstrate how to fill that right now. It's very simple. All you need is an empty syringe. This is a 10 cc syringe. We're just gonna fill it with plain air. It attaches to this balloon that is on the outside of the trach, and it is a lure lock situation. So it kind of connects onto there, and you can see we just inject it like we would anything, and you can see this balloon filling up, and then you can see the trach. You can see Tom's cuff is full there too, so you can see that now it does butt up against the walls of the trachea. If we pull it down, you can see that there's room for air to get around, versus when it's inflated, there's no room and the trach is nice and snug in there. So this is an important piece of the trach. This is sitting on the outside of Tom's body, so you'll see this on the chests of patients in the ICU and on the floors in the hospital. And so we can squeeze that, and that tells us, you can see it's full, so that tells us that inside the body the trach is cuffed. So Tom here is ready to be put on the vent if we need to. The problem with that is because there's no air that's getting around the tracheostomy, there's no air that's getting up to his vocal cords. So Tom is not going to be able to speak like this. We want Tom to be able to speak if he's going to have the trach for a long time. So if he's going home with the trach, if he is off the ventilator but still needs the trach to be in, then we can either just deflate the cuff or we can put in a cuffless trach. So in Tom's case, in the hospital, we would probably just deflate the cuff. So instead of trying to fuss with changing the trach out, we just deflate it and inflate it. In regular life, if Tom was going home, he's not necessarily going to want to have to fuss with his little dangly bit here. It's going to be kind of cumbersome for getting around and doing things. So we want to put him on an uncuffed trach. So the uncuffed trach is the same thing, it just doesn't have a cuff. It's a pretty straightforward situation there. So we'll open this up. This is a size 7 uncuffed trach, so it's a little bit bigger, so you can kind of see the difference there as well. So we have the bits that come in a case. If you ever replace a trach, you'll have it kind of, so this is the brand new kit. So you have your obturator here, your kind of janky trach tie there, which isn't the pretty one. It's not the Velcro one that we prefer, but it does in a pinch. You have your inner cannula, and then you have your outer cannula trach. So before we ever would put something back in, we want to assemble it so that it's good to go. This one actually has 2 inner cannulas, which is handy. So if we were putting it in, we would put the obturator in, but we'll leave it like this for now. So this is just the uncuffed trach. So you can see it has no cuff. If we were to change Tom out for that one right now, then you can see how it would fit in the airway differently. We'll pull him out. Normally we would not roughhouse our patients to quite the same degree, but Tom is a pretty willing patient. So this would be how the uncuffed trach fits in the airway. You see it's got a lot more wiggle room, and obviously you'd have ties on it so it wouldn't be wiggling so much, but it has a lot more wiggle room. It's a lot less invasive in the airway than the cuffed version. The problem with that is that if Tom ever were to need to be emergently put on a ventilator, we would have to stop what we're doing and swap the trachs out so that we had the correct trach, so that we could actually get him ventilated properly. So in hospitalized patients, that's usually something that we keep from doing until the very last minute to prevent having any complications. Let's see, and then you have less of a risk of aspiration with the cuffed trach because you're not getting the secretions from your mouth into your lungs. You're not getting any water or anything like that from your mouth into your lungs. If you were having like a little bit of a diet, like some people on a like chronic ventilator will eat a little bit, that cuff is going to prevent any food or anything from getting into the lungs. So yeah, so that's kind of the difference between cuffed and uncuffed trachs. So moving along. So common causes of tracheostomy placement, like what causes this trach to get put in the first place. So airway blockage is a common cause. So those would be our patients who have some sort of like throat cancer and a tumor that's blocking the airway. Even like a benign growth that's blocking the airway, something like that could cause a need for an airway that is lower down. People with diphtheria can end up needing a trach, things of that variety, like where there's airway swelling as well. Respiratory failure is probably the most common cause that we see in the hospital. Patients have respiratory failure. They've been in the ICU for some time. We kept them on a ventilator. They still need the ventilator, but are unable to be weaned from it, and so we need something that's more stable. You can have the swollen or blocked airway, so like we were saying, that can be due to various reasons, but also like inhalation of harmful material like smoke or steam or other gases. So like smoke inhalation, patients can often end up needing a trach. Cancer of the throat and neck, surgery around the larynx. So if you needed some sort of planned procedure, like radical neck dissections for head and neck cancer, we'll sometimes have them, where you just need a protected airway while you do a lot of messing in the structures around the neck. And then inability to wean the ventilator is the biggest. So your nursing care of a tracheostomy, this is kind of your daily care. They need to be suctioned frequently. So we have a suction catheter, and we'll go into more detail about suction in a little bit. But suctioning depends greatly on the patient. Some patients get suctioned maybe once a shift. Some patients get suctioned multiple times a shift, once an hour. Just really depends, and it especially depends on where they are in the trach journey. Your trach care should be performed every 12 hours, and so you usually will have a trach care kit, and that, excuse me, and that will have all the stuff that you need in it to do the trach care. It'll have some scrubby brushes, some Q-tips like these, so it'll take like these cotton applicators, some scrubby brushes, some clean ties, some drain pads, things like that that you need, and then a nice tray that you can use to clean it. So we'll watch a girl do some trach care here in a second, but just to kind of go through the things we have. So we have our Q-tips here, so our little sterile applicators. So we'll use those to clean, and you can kind of see down here, around his stoma, so that we're getting the skin around the stoma nice and clean, since you can have drainage and kind of ulceration of the skin. Then we're going to get the flange clean, the outer cannula as much as possible clean. You're not going to go inside and clean the outer cannula, but you want to clean as much around the surface of it. Then you're going to pop out your, use this tray. You're going to pop out your inner cannula. You're going to toss them. Pretty much now everyone is a disposable cannula. There was a time where you had a fair amount of non-disposable inner cannulas, but people were disposing them and they were getting stuck, so we've kind of moved away from those. So you'll pretty much always have a disposable at this point. Then your oral hygiene should be done every 4 hours on dependent patients. So that's most of our hospitalized patients. We should be doing oral hygiene every 4 hours on those patients. Then your ambulatory trach patients, we really want to emphasize the importance of oral hygiene every twice a day, usually more like 3 times a day if possible. And then we also want to apply mouth moisturizer to prevent having cracks in the mucous membranes, especially for the hospitalized patients. If that mucous membrane breaks down, then you can get some ventilator-associated pneumonias and conditions like that that are associated with increased mortality and morbidity. So we're going to watch this lovely lady here do some trach care. So she's got her tray. She's using peroxide, which we don't use as much anymore. And she's using some sort of medicated ointment there, likely because she has some skin breakdown. So that's not the norm, but some patients will have skin issues that require some sort of medication. So then here is a lovely, one of our friends, Manny Quinn, and he is going to teach us about trach care of the hospitalized patient.
Quick overview of trach care. First, let's do hand hygiene and don sterile gloves. Next, we're going to set up our sterile field. Be mindful of the 1-inch border. Then we're going to remove the inner cannula and clean the inside and outside with saline and a brush. If an infection is present, be sure to follow facility protocol on the use of other cleansing agents. Then you're going to dry the cannula. Next, we will reinsert the inner cannula. You want to make sure you hear that click. Now we clean both the outer cannula and the stoma. You want to pat it completely dry. Lastly, replace the split gauze and trach ties. We replace one strap at a time. So in a situation where a patient begins to cough, the cannula won't be dislodged. And that's all for trach care. If you're starting nursing school clinicals soon, the clinical...
All right, we'll skip that little plug she had at the end there. A really important point she brought up was with the trach ties. We want to make sure that we're replacing one side at a time. The leading cause of accidental decannulation of a trach is loose ties, and often happens in that changing period. So kind of an area that we want to be careful on. So we're gonna kind of skip the demonstration. I do not have a trach care kit with me today, but kind of know that you're going around that stoma, around what's exposed of the outer cannula, changing the inner cannula, and getting some fresh ties on. That's a big thing in our hospitalized patients, is we don't change our ties very often, and that is one thing that we need to really be doing. All right, your complications of tracheostomies. Excuse me. You have two kind of categories of complications. You have early complications and late complications. Your early complications are going to be the ones that you are experiencing shortly after the trach is put in. The late ones are going to be kind of once it's been in for weeks, months, years, etc. So your early complications, as with any surgery, there's always a risk of bleeding and hemorrhage, and especially being in such a vascular area, it can be a problem there. As I talked about, accidental tube dislodgement or just decannulation, especially in the time where people are adjusting, having a trach in, and might not be used to kind of the body mechanics involved, and they sleep a certain way usually, and they get their hands tangled up in it, things like that. Pneumothorax, so anytime you're messing with the respiratory system like that and creating an opening that was not there, there's a chance of air getting where it's not supposed to be. So pneumothorax or a pneumomediastinum as well. Subcutaneous emphysema, kind of that same train of thought, that there's air that's gotten into places where it shouldn't be, and then you have the subcutaneous emphysema. So anytime we're opening the body up to air getting into places in a way that it was not naturally made, we kind of have some of those risks. So then you can have the stoma infection or ulceration. So like we talked about with the trach care, it's really important to get that stoma clean. And if it does start having signs of ulceration, to get some sort of medication on there so that it prevents it from becoming really bad. And then this is an important part of this slide to note. In the early complications, we have dysphagia with a G, and in the late complications, we have dysphagia with an S. So it kind of makes it a little bit confusing. So in the early complications, dysphagia, so difficulty swallowing. In the late complications, you're having more with difficulty with speech. You also can have some tracheostodosis or tracheomalacia as the tube has been in longer, like the longer it's been in. So anytime you have some sort of foreign body that the airway is getting accustomed to, it can sometimes have some scar tissue and tighten around it. Then pneumonia is the most common late complication of tracheostomies, and that is just because you've created an opening to the airway that is no longer being filtered through the pharynx. So the pharynx usually is able to kind of act as like your HEPA filter to the world and pull out any pathogens or dirt, dust, debris, things like that might normally make you sick or have allergic reactions. And since we're bypassing the pharynx, that is not really occurring anymore. So you can have some increased incidences of pneumonia. Aspiration is a big one because, again, you've created a false opening to the lungs. There's more ways for things to get in there than there were before. And also that just also goes hand in hand with the patient population that has trachs are just very much more prone to aspiration in the first place. You can get fistulas, so it is not uncommon to get fistulas between the trachea and the esophagus, and that's usually from a trach that is too large. So if you have the size that's butting up against the walls of the trachea, can kind of rub and create an opening there. Accidental decannulation, again, remains a big problem, is always kind of one of the complications to be on the lookout for, just because it is a foreign body into the body that is not sewed down and not really secured in any way. So if the trach ties fail, there's nothing really holding it in place. And then mucus plugging is a very common one as well, where just, especially if you have people who aren't humidifying their trachs or aren't using much humidity, then you can get these large mucus plugs because you're not breathing in humidified air through the pharynx. So your emergency complications that are going to cause you immediate problems are your accidental decannulation and your mucus plugging. So accidental decannulation, because you no longer have the airway in. If it is someone who's on a ventilator, especially, that's going to be problematic. And someone who's not really able to maintain their own airway might not be able to continue breathing. So that's something that we need to get replaced as soon as possible. The first step is to ensure that the patient is stable and in no acute distress. If they're not in any distress, then you can kind of take your time and breathe and center before you start trying to put the trach back in. And you can kind of be a little bit more cautious and, just kind of take your time. If the patient is unstable and they're really desatting, then you kind of just got to get it down and dirty back in. And that's not, anyone's preference, but if that is the case, you got to get it in as quickly as you can. If the patient is in acute distress, in the time it's taking you to get all of these supplies ready and get all the pieces together and all that, then you can bag the stoma. So we'll talk about that again later when we're talking about bagging. But you can use the mouthpiece as if you were going over someone's mouth. You can just put that over the stoma, and it will kind of occlude the stoma and act as a little bit of a support until you can get the airway back in. So mucus plugging, that is another important complication. So the plug can either be in the cannula or down further in the airway. So if we turn to Tom here, we'll take the trach and put it back in. And so if we're talking about using this as a little segue, talking about replacing the trach, it is sometimes easier when you replace it to go upside down. So if you kind of get it like this and then twist and plop it in, it's a lot easier than if you're trying to go just like this and you're kind of hitting the walls. As you can see, it kind of goes up. So if you're going in upside down and then twisting it into place, and then you have your trach in place. So if you have a mucus plug, it can occur in the cannula here, or it can occur further down the respiratory tract here. Ideally, if we're going to have a mucus plug, we would like it to occur in the cannula because that's a lot easier to fix. If that does happen, then you just remove the inner cannula with the mucus plug, throw it in the trash, and put a new one in. Make sure you suction the outer cannula without the inner cannula well to make sure that you've gotten any remaining mucus, and then just put a new inner cannula in. If it is lower in the respiratory tract, then you'll have to suction. That is when I would recommend calling a respiratory therapist, because they're much more skilled at that kind of maneuvering. They can put a little bit of saline in there sometimes to break up the plugs and get things out, but that is something that I would let a respiratory therapist do. So we'll put Tom back there. If the plug is in the airway and you can't get it out and the patient is in distress, then bag the patient and call for the respiratory help. Sometimes just bagging the patient also can help kind of get the mucus plug out and kind of push it along. So what do I do if the trach becomes dislodged? As we talked about, first assess the patient. That is always your primary action, is assess the patient, make sure they're okay. If they are not in acute distress, then just monitor them. Get all your supplies together to put the trach back in and slide it back in comfortably. If you're having issues with it getting back in, then call for help. But as long as the patient is satting okay, then they're okay for the trach to be out. If the patient is not satting okay and is in distress, then obviously that's a different conversation. So in that case, we want to put the bag valve mask or the ambu bag over the stoma with the mouthpiece and ventilate there. And then we want to, when we replace the trach, always, instead of just kind of shoving it in willy-nilly, if we look at the bottom of these trachs, if you can kind of see them, they're very sharp and pointy. So we don't really want that jabbing in the airways. So the trachs come with this, which is called an obturator, you can see. And so it has a nice dull end. So when we slide it in the trach like an inner cannula, it causes this nice dull end to the trach instead of such a sharp end. So we want to make sure that we have in the room the size, so say we're a size 6, we want to have the size 6 trach, a size 4 trach, and the obturator. Usually you'll see the obturators in a little Ziploc baggie hanging above the bed. And then if you can't get the trach in, and it's just, sometimes we have people that the stoma starts to close immediately, or I've had patients where they've pulled the trach repeatedly and so there's a lot of scar tissue. In that case, you're going to want to call the MD and call the respiratory therapist and have somebody else attempt to put it in. And they have some tricks and stuff that they can do to make that happen. So your emergency preparedness, these are your supplies that we're talking about that should always be at the bedside. We always want to have the bag valve mask or the ambu bag. We want the current size trach and one size smaller. That way, if the stoma does begin to close, you'll have a smaller size trach that you can replace it with. Then you want the obturator, and then since we are nice people, we want some lubricant, which I've lost my lubricant. So you want just like one of the little packets of lubricant that you can get from the supply closet, and that just makes it go down easier. Then you're going to want several sizes of suction catheters. So your suction catheters will all say what size they are on them. I say that as this one does not say. This one is a 14 French. So you'll see different size suction catheters in the supply closets. You'll want to have like a 14, a 12, a 10, just to have some different options in case you can't pass one size, or if there's a plug that's too big for a smaller size, things like that. And then you want to have extra ties just in case. Always have a couple sets of extra ties in the room in case something happens to them. So here is a video showing how to replace the trach. If I can get it to work. Well, I'm sorry, that's not working, so we're going to skip it. Sorry. So we demonstrated kind of as we went there how to replace the trach and what that looks like. So we're going to do a quick knowledge check now that we've kind of learned some things and kind of see where we're at. So what is the most common late complication of a tracheostomy? Have pneumonia, mucus plugging, accidental dislodgement, or hemorrhage. So the answer is, I'm not sure if you can see that, but the answer is pneumonia. So as we talked about, the not having the filter that the pharynx provides and kind of all that dust, dirt, and debris and just germs from the environment getting into the airway causes a high risk of pneumonia in trach patients. Right. The main cause for accidental decannulation is loose trach ties, inner cannula that is too short, forceful cough, or both A and C. So the answer to this is going to be both A and C. So having a forceful cough can sometimes send the trach flying because there's not anything holding it on, and having loose trach ties. So sometimes those happen together, sometimes they happen separately. But certainly if you have loose trach ties and a forceful cough, you have a recipe for a disaster. So both A and C. So we're going to do a case study here. So the next several questions relate to this case study. Frank is a 78-year-old man. He's got a size 6 Shiley tracheostomy. He is not on a ventilator and he uses a trach collar for humidity. He lives at home and his wife helps care for him, but neither of them has any sort of like formal medical training. Over several days, he's developed a persistent cough. One day he had a coughing attack and coughed so hard that his trach became dislodged. What is the first thing that they should do? So call 911, assess Frank's vital signs, including his pulse ox. You know, Frank's wife, Linda, is a worrier, so she is going to panic. Just panic. That's all she's going to do. And then we're going to clean the stoma site because, you know, the trach is out. We don't really get to, like, get up in there very often, so we're going to take advantage of that situation. So as I'm sure you can all guess, we're going to assess Frank's vital signs, including pulse ox, and determine that he is stable. So what are we going to do next? Again, call 911. Prepare to clean or prepare to replace the trach, bag his stoma, or Linda is just going to cry. So we're going to prepare to replace the trach. What supplies should they have at the ready for situations like this? So out of this list, we're going to select the ones that we do want to have at the bedside. So we have a new size 6 trach, an endotracheal tube, a size 4 trach, a sharps box, a suture removal kit, lubricant, an obturator, a ventilator, or a bag valve mask. So we're going to want to have the new size 6 trach, a new size 4 trach, the lubricant, the obturator, the ventilator, not the ventilator, but the bag valve mask. So then, since we were planning to do this education in person originally, this is where we would have a volunteer come show us on Tracheostomy Tom how to replace the trach. But since we are apart, we will not do it that way. So now we're going to talk about total laryngectomies. Total laryngectomy is where the larynx is entirely surgically removed. This means that the mouth and nose no longer connect to the lungs. A tracheostoma is formed where the upper end of the trachea is attached to the skin of the anterior neck, creating the stoma. So you have kind of the trachea tube, and the top of it is connected to the skin. So instead of on tracheostomy Tom, this being how his trachea looks, he's going to be missing this entire piece, and the top of the airway here is pulled out onto the skin. So that is why laryngectomy patients don't have to have a tube. Their stoma will stay mostly open without one because it's not the same just incision into the trachea like a tracheostomy is. So this usually results in the loss of the sense of smell and taste. A lot of the times patients can't speak because their vocal cords are removed, and they're unable to smell or taste because they can't really breathe through their nose because the air is coming through their throat, so they're not really getting those sensory bits from the nose. So this is just kind of a diagram showing what that looks like. So laryngectomies use a Lary tube. So this is similar to a trach, but it is not the same. They are not interchangeable. They are distinctly different things. So the Lary tube is going to sit in the trachea in the same way that a tracheostomy does, but these tubes are a little bit different because it's really just providing some structure to the anatomy there and giving a pathway for us to suction without irritating the skin. So this is a Lary tube. So you can see it is very different looking than the trach. It is a very squishy, I don't know if you can see how squishy it is, very squishy silicone. So that is going to sit in the same way that a trach sits, just in that stoma, and sit into the trachea, but it's a little bit shorter. So you can see there he is on tracheostomy Tom, a little bit shorter, a little bit different from the outside. So that is mostly just to give a little bit of structure. The stoma is not going to close entirely, but it can stenose. So we want to make sure that it has a little bit of support to keep it as open as possible. Then it's also going to be to provide a place to put HME valves and speaking valves. So we want the airway to continue to be humidified. So we need some sort of a device that can hold a humidification, so we don't have to have our patients hooked up to a trach collar and hooked up to the wall all the time. So we'll talk more about those HME valves in a little bit as well. So we also use ties like a tracheostomy to attach it to the neck. So these are the ties that kind of come from the laryngectomy or the Lary tube manufacturers. So you can see they're like just normal trach ties. You can adjust them on the back here for the length around the neck. And so then we have our demonstration we just did as well. So your causes for your laryngectomies, they're almost exclusively going to be because of laryngeal cancer. There occasionally are laryngectomies because of trauma. So rarely you'll have someone who has a gunshot to the larynx or a stab wound to the larynx that they do a laryngectomy for and have a Lary tube as a result, but it is almost exclusively due to laryngeal cancer. So the biggest, most important takeaway from laryngectomies is that they do not have an upper airway any longer. We have fully surgically excised that. So we cannot bag them from their mouth or face. We cannot put them on oxygen through their nose or mouth. We can't put them on BiPAP or CPAP. And so because of that, it kind of limits our treatment options. So they have to have a trach collar for oxygen if they need oxygen supplementation, and they have to be intubated through the stoma, and they have to have the just like Lary tube for any sort of humidification. So that is the biggest, most important takeaway of this entire education. If you remember nothing else, remember that you cannot bag laryngectomy patients through the mouth. You have to bag over the stoma. So because of that, you should have at the bedside a sign like this one, or I have one here that says that they are a total neck breather, or this one says this patient has a laryngectomy. Kind of varies depending on your facility. So see, total neck breather, total laryngectomy. This one says that they have an HME valve in use. That is important because if you were to need to intubate them or bag them or anything like that, you would need to remove that. So also important to note. In the case of this one, they just have some information about the laryngectomy tube on this card as well. So it has kind of just other information that that patient might need to know. But it depends on your hospital what those look like. So we talked about in an emergency, you need to use the ambu bag on the stoma. Usually we prefer that you use an ambu bag with a pediatric mouthpiece or an infant mouthpiece. That way it just fits over the stoma a little bit better. And so it's the most important nursing consideration about laryngectomies, and the most important difference to note between laryngectomies and tracheostomies. So daily care of your laryngectomies, it's very similar to a tracheostomy, but you don't necessarily care for the tube in the same way. So you'll often see the stoma kind of out and about like this. So you're going to want to wipe it down, keep it clean, just get everything as clean as possible. The biggest difference, I think, is in tracheostomies, you try really, really hard not to have the tube come out, and laryngectomies, you want the tube to come out every day. So you're going to want to remove this entire thing, clean all around it, get all of the gunk out that you can. Then this tube, this little very not exciting looking tube here, is extremely expensive. Each one of these tubes is about $250 to $300, depending on your insurance provider and some things. So we really want to try hard not to lose these because our patients will hate us. And they're very hard to get replaced as well. So all you do for this is just kind of the technical best practice is to rinse it with some sterile water. A lot of times they'll just rinse it under the sink, get any gunk, like big pieces of stuff out. Then you'll want to kind of clean it like you would with the trach care with the Q-tips and kind of things like that to make sure we've gotten all of the kind of stubborn goop and stuff like that off. And we want to be very careful to clean the skin around the stoma, like we said, because as we talked about with the trachs and with the Lary tubes, the skin is very prone to break down, and we really want to try hard to avoid that. So your complications of laryngectomies, your early complications are going to be bleeding. You can get a pharyngocutaneous or pharyngotracheal fistula. And I'm not honestly going to try and explain what those are because it's kind of above my pay grade. But you can get kind of fistulas where things go different places and it's a surgical complication. You can get a hematoma or a seroma. So that is a blood pooling in the neck or serous fluid pooling in the neck. And so that'll be like a large bruise or a large fluid-filled accumulation. Then infection, like with any surgery, any opening into the body, a high risk of infection. Late complications are going to be pharyngoesophageal stenosis. And so that is, your throat and your esophagus stenosing because of what's changed with your airway. Then stoma stenosis. So as we talked about, having the Lary tube in there so that we're keeping the stoma patent as much as possible and keeping it from getting narrower, even though it'll still be there. And then hypothyroidism is interestingly a late complication. The most emergent complication is going to be mucus plugging or airway blockage. So that's going to be similar to the tracheostomy. You're going to want to first start with the tube and first make sure there's no blockage in the tube. And if that is clear, then look kind of lower in the airway and manage it very similarly to a tracheostomy. How you would manage that if there's a lower airway mucus plug. So kind of your emergency management of laryngectomies. So kind of your takeaway from this section on laryngectomies is, again, the very most important part is that laryngectomy patients are obligate neck breathers. We cannot bag, oxygenate, ventilate, etc. anywhere other than their stoma on their neck. In a tracheostomy patient, because the airway still does connect, you can bag the mouth and nose and air will still get into the lungs. It's not the most efficient, and bagging them on the stoma is going to be less work for you and better outcome for the patient, but it is not as severely important as it is with laryngectomy. In a tracheostomy, you're still going to get air to the airway if you bag through the nose and mouth, whereas in a laryngectomy, that is not going to happen. And then the most likely cause of distress is mucus plugging. So you want to make sure to remove the Lary tube and make sure it is patent. So we're going to do a quick knowledge check. What condition is most likely to lead to a laryngectomy? So we have respiratory failure, head and neck cancer, airway obstruction. So it's going to be your head and neck cancer, as we talked about, almost exclusively laryngeal cancer. True or false? Tracheostomy tubes and laryngectomy tubes are interchangeable, and you can use either one on either device in a pinch. So that is false. The Lary tube, as we talked about, is much more flexible. It provides a lot more structure, and a Lary tube is not going to be able to be put into a tracheostomy patient because it's just a very different type of stoma. So here's a case study. So George had laryngeal cancer. He had a total laryngectomy. He has a Lary tube that's been in place for a few days. He's been in the hospital since his surgery. He started having pain around his stoma. He's got a very large bruised area that's tender and warm. What complication is George experiencing? George has a hematoma. So he's got that large area of bruising that's warm to the touch. Those are all classic signs of hematoma. So now we're going to talk about HME and passing muir valves, and we're getting close to being finished. HME valves are heat and moisture exchange, or HME, heat and moisture exchange valves. So those provide humidity to the trachs and laryngectomies, and you use them on both. It's a different valve that you use for the different devices, but both of them will use it. So since you're no longer using that pharynx, as we talked about a lot, then you have to have something that's providing humidity. So in the hospital, we'll have a lot of patients that will be on the trach collar from the wall and getting humidity that way. That is not great for people who want to have any sort of freedom and be moving around. So kind of our ambulatory patients will end up being on an HME valve at some point. So you have several options for those. Trachs have two different options. So you have the T valve down here in the corner, and it is kind of your down and dirty HME valve. It gets the job done, but it doesn't have a lot of bells and whistles. It's not the greatest. So this is an example of the T valve. You can kind of see it's got these rolled paper filters at the end that filter the air coming through. So it fits on the end of the trach. So it just kind of slides. Oops, that one doesn't have any cannula on it. It just kind of slides onto the end like so. So you see you have your trach with your inner cannula. This one just kind of pops right there on the end, and it stays in place. And then you breathe through that. It breathes through the sides and humidifies the trach. And then when you're done, just pop it off. These ones are also HME valves for the trach. They have a lot more bells and whistles. So they have where there's a little opening in the middle. I don't know how well you can see where my finger is there. And that you can put a suction tube through. So if you need to suction the trach, you can do that just right through the HME valve. It also kind of pushes down. You see, pushes down when you push on it, and that helps occlude the trach so that they can speak. Then it also has a port on the side where you can hook oxygen to it if you need to. So that one is the same principle as the other. It just, you see, kind of pops on, and then it is on there, and that is what it looks like from the sides. So that is the valves for the trach. The valves for the laryngectomy tube are very similar, but a little bit different. So when they come from the manufacturer, they come in these little blister packs. So you have a daytime valve, or what they call the home valve, and then a night valve. That's going to be your not at home valve. So those are similar but different to the trach valves. The nighttime valve is very similar to the HME valve for the trach. So these fit in the same kind of way. You have your Larry tube and they just kind of squish on the end there, and then you can occlude it to talk, and then you can also go through the sides if you need to suction it with that one. I don't believe these ones have an oxygen port on them, but I'm honestly not super familiar with them, so I'm not sure. Then the daytime valve is a little bit more of a lower profile valve, a little bit nicer looking. So it looks like so, fits on in the same way, and then it occludes kind of deeper so that they can speak more clearly. So this one, and being like this hard plastic, keeps it from getting gucky and kind of gross when you're out and about during the day. So those are your Larry tube valves that come in these blister packs like these. So you'll see this at the bedside, whereas with the trach HME valves, you'll see more like individual packaging. So those act as a filter against dust, dirt, and debris, which is the biggest, most important thing. So we really want to make sure that patients have at least something covering their trach, so they're not getting things directly into their airway. Excuse me. So passing mirror valves are really important. They are what allows most of our trach patients to speak. So the passing mirror valve is a really interesting contraption. The way it works, which I'm not an engineer, so I'm not really totally sure how exactly it works, but you breathe through the trach normally. The air is able to go in the trach, but it occludes it from going out. So the air is forced up through your vocal cords, through your upper airway to get out. So the passing mirror makes it so that you can speak very easily and freely with the trach. You cannot use a passing mirror valve on a laryngectomy because it's a laryngectomy, you've removed the larynx, and so you no longer have the vocal cords for air to get up through. So these fit on the end of the trachs. They're very simple, a little bit more complex than the HME valves, but a similar kind of thing. You have again your trach. So you take this and it's kind of a quarter turn onto it and then a quarter turn off. You don't want to just like shove it on there and turn tight because then it'll get stuck. And if that happens, you have to replace the entire trach, and that's never great. So just kind of a little quarter turn, gets it on there, and then it gets it good and tight. These can get coughed off. So if you have a patient with a really forceful cough, it's not unusual for it to go flying, and then you have to find them because they're also very expensive. They cost about $150 to $200 a valve. So we want to make sure that we don't lose these for our patients. They have a little carrying case that you keep with them that makes it easier to find them. So it also can help patients swallow. So if you're trying to eat with the trach and like relearn how to swallow, because it's kind of mimicking that more normal physiology, you're more able to do that without having the risk of aspiration quite as bad. So your important information to keep in mind about valves: the passing mirror valve, the passing mirror valve has to be removed when they sleep because of the way it alters the airflow into the lungs. It can cause kind of some respiratory distress when patients are asleep if they keep the valve on. HME valves, however, are recommended for sleep. We want patients to sleep in them. They get a lot of good airflow through them, so those are really important. And the HME valves can get kind of gucky with secretions because I'm not sure how clearly you can kind of see, that it's like a piece of foam that's in there. So if you have a lot of secretions, then the foam can get quite full and has to be changed kind of frequently. So some people change them like every 8 hours, some every 12 hours. When you're first using them, some people have to change them much more frequently, like every 4 hours. So here's a little video about a patient experience with a passing ear valve.
A question I get asked a lot is, do I have to cover my trach when I speak? The answer is yes, unless I use a passing ear valve, also known as a speaking valve, or PMV. This is what it looks like. And it just hooks on to the end of my trach. So when you speak, air passes up through your vocal cords in order to talk. When you have a trach, you have a hole in your neck and that air comes out of the neck instead of going up and passing through. So you have to include in order to get the air to go up. The reason why I don't use the passing ear valve very often is because it is harder to breathe with it. You have to actually think about breathing, at least I do. When you wear it, you breathe in through your neck and out through your mouth and nose. Whereas when I don't have it on, I just breathe out of my neck and I don't have to worry about it at all. When I had a bigger tube, I could not talk at all without occluding or without the passing ear. And actually I did go through a period of time where I couldn't talk at all. Now though my trach is smaller, it's a size 6, and a little bit of air does pass through without it. It just makes me very winded and it sounds more breathy like this, versus if I cover it, you can hear me like normal.
All right, so that's a great example of kind of a patient's lived experience with the trach and what having a passing ear is like. So we did the demonstration, about the different valves, and now we're going to kind of learn some of the important nursing skills necessary for trachs and laryngectomies. So the biggest one that we need to be comfortable with is suctioning. So like we talked about, some patients are suctioned once a shift, some are suctioned once an hour. It just kind of depends on how many secretions they have, and it really heavily depends on where they are in their trach journey. Like the earlier the trach, the more secretions you'll have. The longer it's in, the more it kind of adjusts. So we don't want to just suction a patient willy-nilly. You can cause more secretions by doing that. So if we're suctioning a patient super frequently, we can cause them to have more secretions over time, causes a rebound effect. So we want to make sure that we're kind of doing it mindfully. So if there's visible secretions in the airway, so if the cannula is just looking gucky and gross, then it needs to be suctioned. If you're hearing, sometimes you'll hear like from the doorway of the room, kind of just that coarse chest sounds. Sometimes you'll hear them with stethoscope. If that's the case, then we need to suction. If the patient feels like there's guck in the trach, if we think that they have aspirated something down the trach, then we definitely want to suction it. So sometimes in like code blues, you'll have that where you'll suction kind of deeply to see if there's anything aspirated. They just seem like they're short of breath, like they seem like they're having a high work of breathing, then we want to go ahead and suction them. If they're like a ventilated patient who might be like a neuro patient and they're super restless, then we want to suction them as well. And just unrelieved coughing. So you can do oral suctioning with a Yonker, and that's for secretions that are in the oral cavity only. And the Yonker is the hard, firm tubing. I don't believe I have one of those to show you, but it is like the dentist office style tubing. So we don't want to try and put that down the trach, obviously. So the supplies that we need for suctioning, we need the trach, obviously. We need either wall suction or, like we have here, a suction machine. So the suction machine, which you'll see patients that are at home will have, or you'll see these on our crash carts. So this, we won't cut it on because it sounds like an airplane about to take off. But just to give you an idea, this is kind of what she looks like. She's got the on-off switch, all the little different pieces and parts. We aren't using her much currently, so she's kind of tucked away. But you have the canister where suction fills. You've got the tubing that we have kind of wrapped up inside the canister right now. And then you'd have the flexible suction catheter on the end. So that is our machine. In the hospital, we usually have that machine in the wall, so you don't have to have kind of the same device. Let's see, then you want sterile water or saline to rinse the tube with. Usually we use saline in the hospital. In like the home setting, you'll often just use tap water. Then you want gloves. Some people will tell you suctioning is a sterile procedure. It depends on your facility and it depends on their policies and procedures for that. In the home setting, suctioning is going to be a clean procedure. Generally, you want to just make sure you have gloves on and make sure you're treating it as cautiously as possible. And then you're going to want a face shield or glasses, especially if you have someone with a lot of secretions or someone with anything infectious. So your skills checklist here, we're going to gather supplies. So first we want a trach in the patient. That one's not going to stay. Put our other trach in there. Forgive me, it's hard to get in, sorry. Okay, so we want the trach in the patient. So then we're gonna gather a suction catheter and like we talked about the gloves, suction catheter. This catheter brand has a little container in it that you fill up with water that you suction out. Some brands don't, you need to bring a container. Just kind of depends what your hospital stocks. So you wanna always perform your safety steps, make sure it's the right patient, make sure your settings are correct, things like that. Then you're going to want to adjust the bed to a comfortable height, position your patient to a comfortable position. You'll put like a towel or waterproof something on their chest just in case they start kind of having a lot coming out of the trach. You don't want to get them gross. Then you're going to set things up. So this is what this container looks like. It comes flat. You just kind of squish it and it becomes a little box, and it's plastic lined. You can see it's lined with plastic, so we could fill it with water and use it. So we kind of set it ready. Then we have the suction catheter. This brand is the Flexi Seal that is in the plastic. Not all brands are in the plastic. It just depends again what your hospital stocks. So this is going to hook up to your suction on the wall. It's got this little what's called a chimney valve at the end. You can see it's got a place to occlude. So you're going to occlude it with your finger when you are suctioning. So that was a good example of the sound of a trach that needs some suction, is kind of that gucky sound. So you're going to want to hold the button when you are pulling out. You don't want to suction when you're going in. You only want to suction on the removal of the tube. So you're going to put not a ton, you're not going to put this whole entire tube into someone's trachea for general suctioning. So you're going to kind of, depending on your patient, go, about this far. So we're kind of going the length of the tube and then just a little bit farther. If you have like a mucus plug or you're feeling like there's something deeper, then you can go deeper, but we want to kind of start about that far in. So we're going to put this into the tube, hit our button, and then pull it out while kind of spinning. So see if I can do these things. Can I borrow you, sir? Come here for a second. Excuse me, I'm just getting my little helper here is going to help hold tracheostomy Tom so I can demonstrate. All right. Thank you. So this is my father, our resident trach patient, who is going to be our resident shelf for right now. So in the hospital, you have all this hooked up to the wall. This is a patient that is attached to, you know, a body. We're going to take the suction tubing. This is our kind of desired length. We're going to feed it through and down. The base of tracheostomy tom is keeping me from going any further, but I would go a little bit further in reality. Then I'm going to occlude and do this kind of a spiral motion to pull out and then be done. I'm not going to be in doing the suction for more than 10 to 15 seconds at a time, since patients aren't able to breathe. So then you want to give him a minute to recover. He's going to be kind of coughing and needs to catch his breath. After, you know, 20 to 30 seconds, you can go again and kind of just feed it back down. And then you're going to want to kind of do this circular motion as you pull it up, and that'll kind of keep from anything getting stuck to the walls of the trachea. Then you can repeat that procedure up to 3 times, or until the patient sounds like they don't need to be suctioned anymore. Allow 30 seconds to a minute between passes to allow reoxygenation and ventilation. So that was my demonstration for that. All right, thank you to tracheostomy Bill here, who is our lovely helper. So after we have done that suction, we're going to take our little container here and just put the suction in here, again occlude, so that way we pull up water and don't have anything stuck in the suction tubing. This part is not as important. We want the tubing that's going to be permanent, or not permanent, but reusable, that's going between the wall suction and this tubing to be clean. This we're going to throw away after each use. Do not save these, because that is one of my pet peeves when I come in and find these hanging dirty on IV poles and such. So our last section here, we're going to talk about using the bag valve mask or the ambu bag. So that is this sucker. So in the hospital, we can hook this up to the oxygen in the wall, and we should do that whenever we're in the hospital. In the home setting, we don't always have oxygen to hook up to, so that's okay. So this comes one of 2 ways. So in this situation, it is the trach adapter. It also has a mask adapter. So like we've been talking about, if you have to ventilate, if you have to ventilate the patient on the stoma, you're going to use the mask adapter. That's going to just click onto the end here. Ideally, you'd be using a pediatric or an infant mask, because obviously this is a little bit big for a neck, but we kind of use what we got. So if you have a tracheostomy and the tube is in place, then we're going to not use this portion right now. We're going to just use this portion, and it's just going to hook to the end of our trach. So it just kind of clamps on. Usually I have, you know, a person attached, and this is a little easier. So it just kind of clamps on to your person, and then you would just bag through here and make it nice and simple. If you don't have a tracheostomy in place, like if the tube has come out, or if you have a laryngectomy, then you're going to want to use the mask attachment. So again, it just kind of pops onto the end, and you're going to just want to make sure you do the seal like you would if you're doing it over a regular face, and give some good slow breaths. You want to do it over a couple seconds, nice and slow, enough that you're seeing the chest rise and fall. And you want to do 6 to 8 breaths a minute, or excuse me, 8 to 10 breaths a minute. So that's every 6 to 8 seconds. And then, yeah, so that's your bag valve mask. So your knowledge check, which items are related to tracheostomies? We've got a few different pieces here. So this one in the top left, or this one in the bottom right there, is related to the trach. The top left is not. The top right is not. And then that middle one is, and the bottom left one is as well. So we're going to listen to 2 quick videos, and then that will be all.
The trach was a mistake. That's what someone commented on one of my videos where I was really struggling. And my immediate reaction was to be very offended. But then I realized people are just lacking some context about why I chose the trach. Yes, the trach was absolutely my choice. But it was my choice because I wasn't unconscious, because I was able to make decisions for myself and had the capacity to say no if I wanted to. But that didn't make my situation any less serious or deadly than, say, someone who was unconscious. Okay, maybe slightly less serious, but you get the idea. I was dying. So I got to make the choice whether to get the trach or to die. So when you say the trach was a mistake, what you're actually saying is your choice to live was a mistake. And I will tell you, even though the trach has been a huge struggle, I have not for one moment regretted it. Because I have not for one moment regretted my life. I know some people in my position may have made a different decision, but for me, this was the right one. We all have different limits we are willing to go to stay alive, and different motivating factors to stay alive. And the fact is, I have a lot of motivating factors to stay alive. So therefore, I am willing to go through a lot more suffering than the typical person might in order to stay alive. Additionally, my life was absolutely miserable on non-invasive ventilation. I had headaches all the time. I was in pain, I was having nosebleeds every day, and I was really just not having a good time. Honestly, despite the complications I've had with my trach, it really is much better than non-invasive ventilation ever was. Anyways, I hope that helps you guys to understand why I chose the trach and why I don't regret choosing the trach. The trach was never a mistake for me because my life is not a mistake.
So that's one patient perspective. I think it's important to kind of understand the different perspectives and the different whys people have trachs. She also has, if you can see, I'm not sure how well you can see, this little blue thing on her trach here. That is this. This is a different kind of passing mirror valve. This is one that is used on inline with a ventilator, but we don't see them almost ever. So we've got one more patient story, and that will be all.
So I'm not honestly even sure all the way what the trach does. I think they poke like a hole. They connected into the ventilator through the trach, I believe. But they felt that that was the best thing they could do to give me a fighting chance. I know that there was a lot of fluid and stuff with my lungs and different things in my lungs.
Of note, this patient has been
really
decannulated.
But the thing about the trach is you can't talk, you can't eat or drink. So the craziest thing for me was waking up not being able to talk and having to communicate with my with my phone, trying to text. The only way that I could speak eventually was they would put this special lens on top of the trach that would allow me to speak. First time I heard my voice, I sounded like Batman. And I remember thinking like, oh my God, is this what I'm gonna sound like? They put me through therapy, and when they actually removed the trach, my voice was very weak and scratchy, but I didn't sound like Batman, and I was thankful. The trach was just really tough for me. Also, I'm really squeamish, and so every time they had to clean it, I did not want to see it. I did not want to even think about it. Matter of fact, when I got home and they'd taken it out and started closing up, there was a period of time where I just couldn't even touch it or like even wash around it because I was so like squeamish. But it saved my life. So thank God for the trachs and the doctors. I just want to encourage anybody that God hears your prayers and that God is able to do the miraculous. And there were times the doctors told my parents, like Josh won't be able to sing again, the same, or he won't talk the same. You know, they gave me a 10% chance of coming out. And so my parents had to hear that and have faith and believe God. And the reason why I sing the way I do now is because, like, I know that by scientific reasons I'm not supposed to be here, but God had a bigger plan. And so just trust God's bigger plan.
All right, so those are some just patient perspectives
The trach
on kind of what life with a trach is like. For some people, it is, as they were talking about, a great option. We see a lot of people that struggle with them, but all around they're super interesting things, and I hope you have enjoyed learning today about trachs and laryngectomy tubes. Thank you.